All right. Well, it is top of the hour. I want to welcome everyone to the American Head and Neck Society Recon Round the World. It's our second of four webinars this year that we're hosting. I'm Jeremy Richmond, chair of the Recon section, and I'm joined by my co-chair, Matt Old from Ohio. Um, I want to thank the AHNS for supporting this webinar, especially because it's very early for Christina and the team to join us. Um, as I mentioned, this is the second of four. For those that missed our last one, we traveled to Africa in November, where we discussed mandibular reconstruction in resource-constrained areas. That is available through the AHNS website, and we encourage those that have missed it to log in and check it out. This one likewise will become a video that will be accessible to those that are not with us live today. And I want to remind everyone about our next webinar where we'll be traveling to South America for complex oral cavity reconstruction. And that's going to be on April 24th. So please mark your calendars for that. So without further ado, I want to turn it over to Marian Abuyared from UC Irvine, also Davis, sorry, um, who woke up early as well to host this webinar. Thanks, Marianne.
Yeah, my pleasure. Thanks so much for having us. It was, great putting this together, and we have an awesome group of panelists today who I'll introduce in a moment, and some really great cases and difficult cases to go through together. So we'll keep this very interactive, and hopefully talk about some complicated patients here. And here is just our reminder that AHNS would be a great resource for you all to join, some really great benefits in membership, and the link is below here for applying for membership. So this morning, thank you, Jeremy, for the introduction, but I'll be here kind of moderating among the panelists. I'm Marianne Abuyard at UC Davis Medical Center in Sacramento. We have with us Elizabeth Nicoli from the University of Miami, Sami Melki from the Sheikh Shakbout Medical Center in UAE, Hani Marzuki at the King Abdulaziz University in Saudi Arabia, and Iran Alon at the Sheba Medical Center in Israel. All put together some great cases for you. Just briefly, we'll review nasal defects, including the concepts behind total rhinectomy reconstruction, evaluate difficulties related to periorbital reconstruction, including hardware failures and flap failures, and then finally discuss local versus free tissue transfer when a prosthesis may be best, and when stage reconstruction may be necessary. Briefly, to review midface reconstruction, it's obviously a super complicated area. It forms this bone really forms the borders to our oral cavity containing our dentition, our nasal floor and lateral nasal wall, as well as our orbit. So really housing important structures, supporting a lot of important structures, which makes this devastating when there is a complication, but also really difficult to deal with. There are some pretty good classification systems, which are helpful when thinking about the extent of your defect, when reporting on the extent of your defect. So just wanted to briefly touch on them here. First is the Brown maxillectomy classification, which divides your defect into really vertical and horizontal extents, with the vertical extent in this first row here and ranging from the left-hand side to the right-hand side. And ranging in how much of the palate is involved, and then finally when the orbit is involved, as you can see here, the progression from the Roman numerals 1 through 5, and then Roman numeral 6 being the total rhinectomy defect. And then the OK classification is nice as well. It's mainly looking at palatal and alveolar defects, but it's nice because it can help guide your reconstruction and what reconstruction may work. So there's the class 1A, which does not involve any teeth, class 1B, which is either just the premaxilla, not involving the canines, or the posterior palate, again, not involving the canines. Class 2, where you're having less than half of the palate involved, but now involving one of the canines. So the canine being the key here for this classification system. And then class 3, where you have a total palatectomy or greater than 50% of the palate. And then with these important subclasses F and Z, involving the orbital floor for F or zygoma for Z. And I mentioned that this classification system can become a framework for maybe what type of reconstruction can be used, because you can see here that, in the publication, they provide a little guide based on the type of defect, and then a suggestion for reconstruction. Although there are many possibilities, you don't have to follow this framework necessarily, but it's just a nice start. So we'll also touch on some complications, including flap failure, hardware failure, fistulas, deformity associated with this. And with that, I'll turn it over to our first speaker, Dr. Marzuki, who will go through rhinectomy defects. And then from there, we'll move on to Dr. Melki and Dr. Alan, who have some really complicated mid-face defects to go through. So Dr. Marzuki, I'll turn it over to you. I'll stop sharing my screen now.
So first of all, I would like, before I start, thank you very much, Marian, for putting all this together, and Dr. Jeremy Richmond for your kind invitation. I'm so glad and happy to be here with you today. It's 4 o'clock here in Saudi Arabia. Just finished my OR, and that's just running away from my OR directly to here to be with you. So I'll start with the nasal reconstruction. I'm going to go over a few cases. And also, I'm going to run through some slides of the principle of nasal reconstruction, just for the sake of time. Sir Harold Gillies, one of the most famous New Zealand otolaryngologists, the father of plastic surgery, once said, "A face without its nose is as lost as a sundial without its numen." The nose provides a center of focus. Its color, size, shape, it indicates the character of a man. Thus, one is willing to pay a high price to obtain a new one. Regarding the history of nasal reconstruction, the nasal reconstruction was among the earliest surgical reconstructive procedures. With the first forehead flap was described more than 3,000 years in India, when punishment with a cosmetically deforming excision of the nose they used to do it in India 3,000 years ago. 1597, the arm flap for anterior nasal defect was prescribed. So some cases start with this total. This is a 59-year-old gentleman, healthy, no significant medical problems, who presented with this basal squamous carcinoma at the dorsum of the nose. This is his defect post resection, so almost his total nose was removed. So I'm gonna ask the panelists here about their options of reconstruction. I'm gonna re-put these pictures again at the end of the presentation and see if anybody have any different opinions or different ideas, or they want to change their plan. So any question? Sorry, any suggestions from the panelists? Oh no, Mariana, are you part of the panels? Can I ask you?
Sure. Yeah. So I was going to say, my first thought here is, I would try some cheek advancement for that portion of the defect, kind of get that cheek bilaterally advanced over to cover the bone that's exposed. And his upper lip, I also would try to advance closed rather than putting any new tissue there. I really always try to get lip closed to lip as much as possible, either through rotational flaps or advancement flaps. So that's my initial thought, and then tackling that total rhinectomy defect after would be my next focus.
Yeah, I agree. I mean, I think I would probably work to pull the lip together. You'd have some microstomia, but I still think that ultimately tends to give you a better function in terms of oral competence than having, a big bulky flap with no real tension around the lip. And I think you could probably also, like you said, advance the cheek. And then really the question is, a lot of this would depend on resources available and patient preference, but when you pull all that in, could you then get a prosthesis for the nose and then really just lay in something to form a base for your prosthesis to sit on in the nose? So that would probably be one option, would be to kind of like tackle the lip and the cheek and get down to just the nasal part. I think with the nose, it tends to be a lot of a conversation with the patient in terms
Of course,
of what
he's a healthy guy. All the
Yeah.
options are good for
and
him.
kind of what their goals are. Because I think, you know, with total nasal recon, if we're going at it with a combination of free and local flaps, you know, something for internal lining, bone, external lining. It's a multi-procedure, you know,
Mhm.
and so obviously
What's your
I'm looking for a
preference for
healthy
the
patient.
framework? What's your
Say that
preference
again,
for,
I'm sorry.
what's your preference for framework?
For
For the-
framework, so if I'm gonna tackle this with free tissue, I like to do an osteocutaneous forearm.
Osteoarm, nice idea, yes.
Yeah, that's kind of usually my go-to, and I get kind of I use the bone for the framework, and then I use the skin for internal lining.
Yeah.
And then I try to use like a forehead flap or something on the face, just because I think color match for external coverage is going to be better.
Marian, what are your thoughts about the titanium?
About
Right,
titanium? I'm okay with
for
titanium.
the framework.
Yeah, I'm okay with titanium. I think it works really well, you know, more, you know, very frequently used periorbitally, you know, orbital floor or mesh there. So yeah, titanium, I don't have a problem with, even with radiation or future radiation after the reconstruction. We did have one question from the audience, which is great. Please send in your questions if you have any. I'll try to keep track with them, asking whether the skull base is involved. So the bony, like anterior cranial fossa in this case.
Any
So,
answer?
like if the bone of the skull base was involved at all.
Oh, no, it was intact, yes.
Okay.
All like, wax for some bleeding in the skull base here.
So if I can comment, I mean, when first of all, we
Please.
need to look at the pathology. So this is a basal square, this is a bad actor.
Right.
So this
Yes.
patient is most likely going to need radiation therapy post-operatively. So we need to bring him to a point where he receives his radiation in a timely fashion. So anything that I think of reconstruction should match or meet that deadline. Now, when we look at the defect, I look at the subsites. There are a number of issues that we need to address, I believe. So I think the premaxilla is resected there. Is that correct, honey?
Sorry, again, the last
Premaxilla, the premaxilla
Yeah.
is resected. It's hard to see from the imaging. It was the vestibule, how much of the vestibule or how much of the lip is
No, there is enough lips here, yeah, because
so
it's
usually it
the dorsal
retracts
nose,
back.
the
It looks
cancer,
much
yeah.
worse than it really is.
Yeah, it's just
many
retracted
times.
with the resection, yes.
Yeah, so that's something to take into consideration. Then there's the medial canthi there, that it's again from the picture it's hard to depict. Are those freed up? Are those still attached?
That's freed up, completely freed up. Yeah. Yes,
So we need to consider attacking those and in some fashion. So when I look at this defect, I would probably want to do the most at this initial setting and leave maybe other things for next stages. We definitely need to correct the premaxilla and reconstruct the lip. As for the framework for the nose, there are a number of options. Obviously, a discussion like Elizabeth said with the patient, what are his preferences looking prior to surgery at the potential of undergoing a total rhinectomy. But I think the option of using osseous radial forearm is a great idea also for the premaxilla. So considering putting bone there just to seal off that area and using the skin to kind of cover the envelope for a start, and then reconstructing the nose could be another option. I'm not sure about a paramedian forehead flap, the way things were resected. I don't know if the how much of the vessels there are going to be intact. Probably are, but
They are intact,
yeah, that's another option to put coverage over,
perfect.
and then go from there.
Nice. So I'll go to the second kit for just for the sake of time, because Marianne was asking me to.
Thank you.
So this is another guy who is actually extremely sick. He just had his 10th metallic stent. He's on he's on aspirin, Plavix, and also blood thinners. So we had to do a quick fix for this guy. So that was his lesion involving the lower nose, columella, and also the upper lip. This is the picture from another side view, and that was his defect. I don't know if it's clear here. I'm gonna show you another view from later on in the slides. But so what are you suggesting? He needs a quick fix from my point of view, because like this guy's really sick. Marianne?
So just wanted to clarify here. So it's mainly the nasal tip involved. Looks like, well, probably some of his upper lip that's resected.
The tip is almost okay, just maybe the columella part of the tip, yes.
Oh, I see. So it just needs maybe some support for the tip, and some soft tissue on top. I would say usually a paramedian or something for the tip, but you probably don't want to bring him back to the OR. So I'm a little stumped. I need to think about it a little bit, just given his medical comorbidities. If you're trying to just think a single stage procedure.
How's the inside of the nose? Do you have any option for like a nasoseptal or bringing some tissue out to kind of get that tip covered?
Yeah, most of the nasal septum is intact. It's fine.
So I think
I think in this case, the upper lip. Yes.
I think in this case there are two main options to use. The first being bilateral nasolabial flaps that
Yes.
are very helpful in my mind in these patients, especially in these elderly patients when you want to get that closure, and usually you'll have excess skin to play around with. So I
Nice.
think a nice nasolabial would work. The other issue is the lip, and then there you can consider doing an extended ABIF flap, which
Nice.
which you can under local in 3 to 4 weeks, just detach. You don't have to take them to the OR, but you can do an extended ABIF flap, take it down to the mentum, and really and recruit a lot of soft tissue to bring over and close that defect. And I've used those before, and they actually work remarkably well.
Would you be worried about bilateral nasolabial in a guy with most of his lips, like half of his lips is out in the midline?
Yeah, so I use possibly a combination. So you can use play around with what. First start with one and then see if we need more tissue to it's always hard to see for the pictures, but it's a lot of
I know,
tissue.
yeah.
And but I think those are two strong workhorses to use locally to try to get the functional lip and then closure of that envelope that we're seeing.
Nice. Any other suggestions? Yeah.
I find the paramedian difficult sometimes there. It's really extended to bring it down all the way down there. I always I'm a little bit more optimistic than I really find myself with, and I kind of abandoned that option for these extended over the columella procedures. But
especially in a guy with bad vascular disease, you worry about that distal tip, which is the part that you actually need, and how robust that's going to be. I don't know. So
also part of his hard palate is out, as by the way, in the midline here. Let's go back. Yeah, so we had to do something about the I can't go back. How I can go back? 1 second. Previous.
So you had to complicate things.
Yeah, seriously.
Yeah, it complicates things. So part of the anterior part of the palate is also gone. So yeah, I mean, we all agree we need to do something really local, quick fix, and get him out of the OR as soon as possible. So I don't think anybody will do a free flap for this guy.
You're leading us away from that answer.
What?
You're leading us away from that answer, from doing a free flap.
Yes. Well, I think the patient leading us away from this option because
obviously. But I have to say, I agree, I've had the similar defect, and bilateral nasolabial flap, actually, part of it will help with the lip, because I've done that for columellar reconstruction, then you end up, dropping the lip a lot. So in that particular case where you lost some of the lip, actually probably will fit really nicely in there.
Nice. Marianne, how long I have so I can just tailor my present?
A couple, like three more minutes or so.
3 more minutes? Okay.
Yeah.
I'm just gonna go really quickly, I'll fly through it. So the function of the nose, these are like lots of function. The primary function of the nose is and the face is to look normal, as we all agree. Then the assessing the external nose requires an appreciation of the nose to the rest of the face. So horizontally, the nose hood occupies the mid third of the nose, and looking at the vertical plane, should occupies the middle fifth of the face. The nose itself has different subunits, the 9 subunits, the tip, the columella, the dorsum of the nose, the lateral walls of the nose, also the ali and the triangular facet. So the primary constructive goal is that each component to be restored as closely as possible to its original anatomical state for optimal functional and aesthetic outcome. So the approach for the nasal reconstruction, we have to approach the nose in 3 layers. The cover, which is the skin and subcutaneous fibrofatty tissues, and underline the framework, which is the underlying bony and cartilaginous framework, and then the lining, which is a soft tissue lining of vestibular skin and nasal mucosa. Important consideration, assume patients wish to appear normal. Use the contralateral normal as a guide. Use exact templates to define replacement dimensions. If the defects of the nasal subunit is more than 50%, we have to replace the whole subunit of the nose, not just part of it, to get the best aesthetic outcome. To position the scars in the junctions between the subunits to hide it, and consider DCR if nasolacrimal duct is involved. Important question to ask ourselves: what is missing anatomically? The cover lining or the support. Is the underlying disease process is controlled? As Aaron mentioned in the previous case, are donor tissues available or depleted or devascularized by previous radiation therapy? Does the patient's health limit surgical stages, anesthesia, or techniques, like in the last patient I just showed you? So for the external covering, I'm not gonna go into details. We have to follow the reconstructive ladder. Primary closure sometimes is an option if the lesion is really small, the defect is really small, less than 1 centimeter. Sometimes it's an option. Full thickness skin graft as well is an option for reconstruction, like in this patient. Local flaps will be the best in the face as for better color and texture and better color match, and for less scar contraction and better functional results. There are different, I'm not going to go through details of this. Local advancement flap, transposition flaps, B2Y advancement flap, dorsal nasal flaps, bilobe flaps. This is a transposition flap. This is as well. This is one of my patients. I did the wide resection here. Any ideas? What your preferred reconstruction in this area for the cover? It's only the cover. The framework is fine. The lining is fine. Any suggestions, Sami? The next picture showed what I did. That's why I don't want to show the defect.
Oh, you're still muted, Sami.
Sorry, yeah. So I suppose this is a melanoma that you're showing here, the pigmented lesion.
It's actually a squamous cell carcinoma.
Oh, squamous cell carcinoma. So after you're done with your margin, you could probably do a bilateral advancement flap from both sides. That probably would close. That's an option. You can, obviously, paramedian is always an option. A glabellar flap is an option. And it really depends on how, how big, your final defect. I don't think with the margins that you will have at the end, you're not going to be able to do a bilobe flap, I assume.
Sorry, it was a BCC, Sami. My bad.
Oh,
BCC. It was a small defect.
All right, so small defect. I mean, again, you can try and, if you probably could try and close it primarily with some undermining and or a bilobe flap as well.
Flaps, yeah, that was
Since you're going to have like 5 millimeter margin at most around that.
Yes, we don't need lots more.
Yeah.
Any different ideas? Or should I move forward? So I did a bilobe in this patient. It's quite
Yeah.
big, right? But it's just, I was worried about primary closure will pull the tip up and that's not going to look good. And that was her picture a couple of years ago. Pedicled axial flaps, the malleolabial. This is another patient that I did lining, missing the cartilage. Here we have conchal cartilage and the flap, a local flap, malleolabial flap, nasolabial, in 2 stages. Forehead flaps, the workhorse for nasal reconstruction, as we all agree. For the framework, the bony cartilaginous framework provides the strength and stability of the nose. It is essential to achieve satisfactory aesthetic and functional results. And usually we replace the missing tissue with similar tissues as the best option for reconstruction. There are different options: titanium mesh, radiated cartilage, autogenous cartilage, and bone. So I'm just gonna slide here so I don't want to take all the time. For the bone, there are many options. One of the best options would be the calvarial bone, which was prescribed 2008, the 2-dimensional L-shaped strut for dorsal support, increased tip projection, improved nasal airway, and have a natural feel and appearance of the nose. For the internal lining, there are many options. A lining should be reconstructed with the nasal defect involved in the full thickness involvement. Sometimes the options most commonly I use is the septal mucosal flap, if it's available, like in this patient. This is the septal mucosa for the lining, and then conchal cartilage and the forehead on top. Other options: split thickness skin graft, the patient not going for radiation, a turnover flap to provide lining, composite ear cartilage graft as well, or if it's a total rhinectomy, then a free flap is an option for lining. So what about total nasal reconstruction? This is our guy again. This is the nose post-resection. This is the defect. So in this case, we put here a bony graft and as for a forearm on top for lining, with a titanium mesh on top for framework and a forehead flap for cover. This is picture here, an Abe flap here for the nose, for the lip. So total nasal reconstruction of total nasal defect must consider all 3 components to be replaced. The paramedian forehead flap is the most common option used for reconstruction of the cover. The framework, usually some people use calvarial bone grafts or titanium framework, or the forearm osteocutaneous flap as well, as Marianne mentioned, which is a great idea. Winslow was in 2003 prescribed the L-strut calvarial bone as option for framework reconstruction. This is his paper. Cycli in 2010 prescribed titanium mesh and forehead flap for total rhinectomy. Titanium mesh has no risk of resorption in the radiated field and very low risk of extrusion. It resists the force of contraction and better than bone and cartilage. This is another patient that we put bone, calvarial bone. This is a different patient, calvarial bone strut for the framework and lining with forearm, and a forehead again for the cover. And that's it. I didn't see the pictures for this guy. 1 second. I missed it. Oh my God.
And while you're looking for it, we did have one other question from the audience regarding whether in these cases, are you all putting a tracheostomy for the patient or?
Good question. Not all of them, definitely. But yeah, most of the total rhinectomy we have to do a tracheostomy because of the bulkiness and swelling in the forearm in the beginning.
I usually don't trach most of my mid-face. I won't say, you know, absolute all or never, but I think a lot of them, you know, I always consent the patient for a trach, and I say we look at it in the case and kind of assess swelling, but we'll just keep them on steroids for like 24 to 48 hours and pop a nasal trumpet in, and it really hasn't been a problem. Sometimes if I'm worried about like the flap, like say I had to revise it a couple times intraoperatively, or I think there's a high risk of a take back,
Right.
sometimes that would be a reason to put a trach in, because it just facilitates the return to OR. So those are kind of some things that I think about, but I would say that in general, I tend to avoid trach in these patients.
Yeah, I'm the same way. I tend to avoid it as well for most of the mid-face, even palate patients. But the point that you make about thinking about how complicated the case was, if you're worried if it was tenuous, you know, that's a really great point, because re-intubating them and, you know, having to go back can be complicated. So
Right.
I have a very low threshold to trach the patients. I mean, I feel it's safer, especially if the patient's not going to ICU, and especially if I'm putting a free flap.
yeah.
I don't think you're ever going to be faulted for traching someone. That's kind of what I tell my trainees, you know, the fellows and the residents, like it's, you know.
But it's morbidity for the patient. It's
Yeah.
not an easy, I've moved away from traching, even for oral cavity.
Yeah.
I don't always trach my patients.
Yeah, I think the more posterior your free flap or your construction is going to be, if
Right.
it involves a palate, then yeah, definitely I'm thinking more of a trach. But if it's very anterior, I'd rather not trach them.
So this is the picture of this guy that I told you about. So we did a palatal flap here,
Okay.
flap from both sides. Then I had to do a really quick fix for this guy, and like a Webster modification for the upper lip and advancement from both sides, and a forehead flap on top. I have these nasal prongs on both sides to keep the nasal opening intact, but he was not a cooperative patient. He pulled out the nasal prongs later on, and anyways, his nose looked not bad later on. That's a good support. It still looks like this until today. But now I'm working on getting back to the OR to open his nostrils, so he can breathe from his nose.
Yeah, that's tough.
Yes, tough. Yeah.
Well, thank you so much. I mean, you had put together some incredible cases, so I'm glad we had some good discussion. Difficult defects to deal with for sure. We'll move on to our next speaker, Dr. Alan, if you want to cue yours up next. Sorry if I mixed up the order a couple times, but I think that should be fine. And then someone had asked a question about if they take a biopsy, if we all take a biopsy from the lesion prior to doing the resection and reconstruction. And we do always have a biopsy first, even for the smaller lesions, just so we kind of know what we're dealing with. Of course, if it was a melanoma, you know, you may need to go wider on your margins versus if it's a basal cell or a squamous cell carcinoma. Someone else, feel free to chime in if you have a different answer, but otherwise.
That's our way of managing it as well.
Perfect.
So can you see my screen?
Yes.
You see my share screen? Great. So in the next 10-12 minutes, I'll try to run you through probably one of the most difficult cases I've had to deal with throughout the years. And this was an ongoing, and I'll kind of take you through our trials and our failures and our successes, and see if we can learn a few things about. Okay, so now you can see my disclosure.
Yes.
Okay, so I want to acknowledge Dr. Mark Erkin, who's my mentor and has been following me through this case and been also pivotal in treating this patient, as well as Shaidu Divani, who's our facial plastic surgeon. This was really a ongoing cross Atlantic team effort for this wonderful patient. And so this was a 55-year-old female who presented to us back in 2016 with a T4A maxillary squamous cell carcinoma, which, as you showed the Okai classification, this was a modified Okai classification with the class 3S, S involving skin. really involving the cheek, nose, palato-maxillary complex, a really big defect. And so we, after the ablative team resected the tumor, we were facing a defect that included a missing palate, the alveolar ridge past midline, lateral nasal wall and ala, as well as cheek and soft tissue with all the goals of reconstruction trying to accomplish in mind. And with those reconstructive goals, are usually our workhorses, the fibular free flap to start off with. And so that was our main flap to start off with this lady. However, from the beginning, she wanted to cause difficulties and really showed an absence of her posterior tubular artery. She had a 2-vessel runoff, and we even did an MR because we didn't believe what we were seeing, and this was really and I've seen this a couple of times throughout the years, but it was really unfortunate. So we went and moved on to another bony reconstruction, which is the iliac crest, which is great bony stock. It gives you soft tissue coverage as we wanted, but it does come with a short pedicle, many times needing grafts. Everything worked really well. We reconstructed her without any difficulties, as you can see in the picture. However, we encountered ischemia of the flap, and we salvaged her just with the radial forearm to get some coverage of the soft tissue component and to obturate her to get her as quickly as possible to radiation with this really advanced tumor. She went on to get chemo RT and of course had a significant DVT event throughout her treatment, which she was put on anticoagulation. And even at this point, I didn't, realize that, something's up with this lady. But once she finished her radiation therapy, I sent her off to Mark Erkin, and I said to him, she has one shot. You have a lot more experience than I do. Give it your best. So he did give it his best, and he went on to put in a scapula in place to get again to try to meet our goals of bony reconstruction with the buttresses, the alveolar ridge, and then the soft tissue coverage. However, also this flap failed, and only then did we realize that something was missing here in the big picture, and we went off and she got a full heme workup just to find out she had a factor V Leiden mutation, causing probably all of this. So my guilt trip was half over this difficult failures. So she went on to a 4th reconstructive attempt. This was already a couple years down the road after she completed her radiation therapy, and the idea was to get do a stage reconstruction to get the palate coverage, and then to place in a scapular flap a few months later. And so she had a radial forearm flap put in place. And then the idea was, her neck was already radiated, her vessels were depleted. So putting a radial forearm, we were planning on using the vessels to hook into the scapular flap. But obviously, once the scapular flap was placed, the vessels from the radial forearm were long gone. But at this point, the second scapula did fit in. Mark was able to restore the palatal shelf, dentition, vertical buttress, and she was really good to go there. But she still had significant facial scarring in the face, which was problematic. And you're realizing this woman has a lot of motivation to bring her to the best she could. She was cancer-free and very active and wanted to get back on track with a very active lifestyle. And so she went on, and together with Dr. Erkin, we expanded her and created a very large posterior scalping flap to really reconstitute all the soft tissue of her cheek. And that was accomplished with 2 stages. At that time, she was also dental implants were placed in her scapula to allow for teeth reconstruction. But however, this lady is with her factor V Leiden, even on anticoagulation, she has congestion of her flap. She was salvaged with a few days of leech therapy that worked very well, and that skin really went on to survive, but still had persistent severe ectropion that we needed to correct, lip positioning, and nasal wall reconstruction. So the next step, she had a superiorly based cheek flap, laterally placed to really elevate all that soft tissue to try to treat that ectropion, and that actually worked extremely well. This is all very early from her posterior scalping flap, so the skin still looks like it's went through a lot. It got better with time, obviously. Here you see it further down the road where the skin looks much better. And then she had went on to a paramedian forehead flap reconstruction for nasal wall. And then we were left with the restoration of her vertical height to the lip. And with that, we went on to perform Abbott flap. But again, she had venous congestion. This lady loves leeches. This is I've never met a woman that had so many leeches put on her ever in my life. But again, it really worked well, and her flap survived, and we were able to really meet most of all our goals. We did not treat her nasolacrimal apparatus, as her eyes were doing fine and she wasn't complaining. She really had enough. So, and we're still at it, refining, little flaps here, little flaps there. She's all into getting herself looking better. But this was her course, and it was really an extensive course. It started in 2016. She went on to have 5 free flaps, 2 of which failed, multiple local regional flaps placed, again with challenges along the road. And this is how she looked in 2015, just a little before her diagnoses. And this is a very recent picture, and we can see that she really you can't see because of the coverage of the eye, but her ectropion was fixed. She has nice almost light color matching skin of her cheek. She has a functional lip. There's no the vertical height of her lip has been really extended very nicely. She has dentition. She's eating everything. She's happy and quiet and doing very well functionally. So what have I learned from this experience is that the importance of patient motivation and physicians' perseverance is really important. I even said, stubbornness. We were really we did not give up on this lady. And don't always blame yourself. If something seems off, look for a tangible explanation. I should have figured out much earlier in her reconstruction process that something was off. It took us 2 flaps to fail, a DVT for us to realize that there's something going on. And a stepwise approach is really sometimes a really good way to do things, not rush to do everything at once. And I think that paid off very well in her case. And have patience, things will pay off in the long run. And finally, it's not always about free flaps. I think this reconstructive challenge really showed us that old and true flaps do wonders. I mean, we've really utilized almost any and every regional flap we could think of to get her down the roads, and so do leeches do wonder as well. So always keep those in mind. And I think that's it. If anybody has any points to make or questions?
So I had a patient, otherwise kind of healthy, kill 2 flaps on me about a year and a half ago.
I feel bad for you.
And what we did a heme workup, and he was
Yeah.
hypercoagulable, and so
Right.
I've become much quicker to kind of pull the trigger on that heme workup. Like if someone's in house and
Right.
you know the flap goes down and something doesn't make sense and we can't salvage it, I consider sending them after the first down flap. You know, I'm not doing anything consistently pre-operatively unless there is another like family history or a personal history of a clot. But you know, this happens, and I think that like I said, I'm more aware of that now, and hopefully other people maybe listening can learn from our misses to consider that earlier on.
Sure. I've learned that lesson the hard way as well. So absolutely.
Do you find that then you're doing the case on full anticoagulation, or do you change your post flap anticoagulation, you know, put them on a heparin drip, or what have you guys found?
Yeah.
So,
Oh, go ahead.
Go ahead.
You know, I do full anticoagulation post-op if someone's hypercoagulable. I don't, you know, I find heparin drips for some reason at our institution are very difficult to manage. They're either subtherapeutic or insanely high. And so I started just putting them on full dose Lovenox. And it's been easier to manage, and it's been less of an issue than trying to mess around with the heparin drip. So that's what I've been doing.
Yes, I do exactly the same. Low molecular weight heparin. I stopped doing the drips. Nobody can manage these drips. We overshoot, we undershoot, and it's just painful. So we just put full low molecular weight anticoagulation, and it's worked very well. We see really little complications. I usually operate on aspirin on most of all of my patients. I put them on aspirin day before and approximately a month out from surgery. That's my routine. I don't do I do anticoagulation for patients that are not mobilizing well. Otherwise, I don't use anticoagulations hardly at all, and you don't rarely see problems with that.
I usually put them on aspirin and just prophylactic heparin or prophylactic low molecular heparin. I put them on drip only if it's a take back. Only if a patient needed a take back. Just I had a bad experience with this heparin drips, hematomas, and I had to take back 2 or 3 patients because I put them on a drip regularly. So I just put them if I have to take them back.
Perfect. I'm gonna have us move on to Dr. Melky's case, although you brought up a lot of really interesting points, Dr. Alon, and wanted to ask you about the iliac crest, but maybe we can probably touch on that with our next case too. So thank you so much. And then someone asked us to clarify the alternative to the heparin drip. We were talking about Lovenox, so subcutaneous Lovenox that you can give as a therapeutic dose twice a day. So an injection that the nurses can administer, or even the patient administers at home sometimes when they're bridging off of other anticoagulation. So just a little bit easier to manage, you don't have to monitor the PTT as often, so.
All right, well, my case seemed rather simple now and quaint in comparison. Well, thanks again for the very kind invitation. And, you know, that case that I'm presenting has kept me up at night, both figuratively and physically. So that gentleman is in his 50s. And I say 50s because I've been taking care of him for the past 4 years, still in his 50s. The case I'm presenting had a right-sided maxillary adenoid cystic carcinoma. And his initial surgery was in 2018 in Lebanon. And all of these surgeries happened in Lebanon, in Beirut. So he had the maxillectomy, which included half of the hard palate, soft pad, the entire maxilla on the right side, the orbital floor, part of nasal bone, medial orbital wall, and the septum. And at the time of the
We're not seeing your
the-
slides advance if you were meaning to advance them.
I'm not advancing them
Okay,
yet.
got it. Okay.
Yeah. So at the time of the initial surgery, in I think it was November 2018, he got a fibula free flap, and then everything went well. He got radiation, and then the problems started. So at that time, first that midline wound opened up. That's probably in early 2019 after radiation. And these pictures are on March 4, 2020, when I first saw him in clinic. So at the time, they did a temporalis fascia flap to cover the area, but that didn't work. It reopened. And so the patient showed up eventually March 4. Now, the timeline is important because March 4, 2020, that's basically 11 days where worldwide we went into lockdown everywhere. And so that patient where, I saw him, he had this bone exposed in the nose. And so, laser pointer. So the bone here, the mesh of the orbital wall exposed here. Here you can't really see it, but the skin is really thin, and I could feel the bone just under it, and eventually it will open and burst and become purulent. And so we want to take him to the OR and basically debride it, remove all the exposed plates and expose the bone. But then lockdown happened, and that got delayed until June 24th. So that's when we first were able to get him to the OR. And at that point, we made the case that he had purulence coming out because the lockdown in Lebanon got lifted early July, but they let us do this case. We debrided, removed all the dead bone, everything that was exposed. I trimmed the orbital mesh. So everything that I could see, I trimmed it, and I kept the rest of it that was covered with the normal bleeding tissues. And so I didn't want to remove it because I thought I was going to have diplopia. I removed the bony support. And we took cultures, 6 weeks of antibiotics. His recovery was complicated. This malar wound that you see on the here didn't stop to keep pouring out pus. And he's a big smoker, still smokes. That doesn't help. And just also to show, this was not a free flap failure because that's a fibula skin paddle here in the palate, and it had healed well from the initial surgery. So it was more a case of osteomyelitis or post-radiation. So on October 29th, again, there was more delays. August 4th, we had the big explosion in the port of Beirut. The hostel where he had his initial surgery got damaged, so we did another hostel, still for debridement. At this point, I decided I'm going to remove everything that I see, plates, the orbital mesh, and everything that we could see, gave him longer course of antibiotics, and then we closed the wound. At that point, he really, the wound's closed. We closed also a small or nasal fistula here. He did fine at that point. We obviously talked to him, said, you know what, you probably need another fibula to reconstruct everything. And he lost his insurance, obviously. So that was a problem because he couldn't then, get that other surgery. And we, at that time, still with the uncertainties happening in Lebanon, we talked to him about, well, what about a prosthesis? And he got excited about that. So he went to see a prosthetist to get that fitted, both a dentition with obturator and then a prosthesis for his nose. And then his prosthodontist calls me, said, you know what, I need all his wounds to be closed, like the nasal wound. You need to do something about that. So I said, fine. And, the thing is, he also developed a frontal sinus mucocele because he had still a plate right up there. So opened them up at that point. And so the plan here, I thought, okay, we're not going to do major reconstruction. He's going to get a prosthesis. The skin on the right side looks really awful. I'm going to do a paramedian forehead flap. I drilled down the frontal sinus, put down the paramedial, and then I lifted a supraclavicular flap. I thought, why not give him a soft tissue local flap in the cheek, revitalize this area, and give him a little bit of projection. And this flap reached just under his orbit, so also use something to support. Soft tissue flap, not the best, but I thought, why not? Why not try that? So I did that. And then, so I pre-elevated to delay the elevation of the flap so I could get more reach. And in December of 2021, this is when I lifted the supraclavicular, placed it, it reached all the way under his orbit. I thought, this is great. And this really helped with the skin quality and with his facial symmetry, trimmed the dog ear on the paramedian. And then at this point, he tells me, I have a small lump here, and it's very painful. And so I thought, okay, there's no plate. I go and remove a grain of rice, small white lesion. I thought it was an aroma. Turns out it's another adenoid cystic carcinoma. We're in an area that probably has not been dissected before. So I have a dilemma because now, okay, at this point also, he decided he doesn't want a prosthesis. He tried to obturate it, it doesn't work. He wants a big surgery, but he has adenoid cystic carcinoma in there. So I said, you know what, we're going to wait. He's still smoking. I scan him multiple times and MRI him, make sure there's no disease anywhere. And I noticed now in July of 2023, my beautiful flap is now back in the shoulder because obviously soft tissue just come down. It's to me, pretty complex case. So we put in a team. I have my partner as well as his mentors, plastic surgeons, help us to decide what to do with this case. Basically, we decided we're going to do another fibula. We considered doing a scapula, but we thought the vessels are going to be too short. We didn't want to use vein graft. And we needed a lot of bone. We needed to put bone under the orbital rim. We need to put bone again in the horizontal buttress, the zygomatico maxillary buttress. We considered an ALT. We said soft tissue doesn't work. So fibula it is. So that was his skull. I don't know if this is going to play. Hope it plays. Anyway, to show that basically this is the remnant of a bone from his initial fibula. It didn't really heal with the zygoma here, and very thin attachment here to the maxilla. And so that's the rest. No orbital floor, no medial wall. So we 3D printed this, and we practiced with the 3D printed this fibula as well, and to just see how we could, design and mess around with it and see how it would fit. So we decided on two osteotomies, 3 segments, one for the orbital floor, one for the zygoma, and then one in between. And so that's what we did. Oh, it works. So we reopened the wound. That's how the wound would have looked like, initially. We put an orbital mesh for the floor, put the bone, one of the bone piece here, one of the bone piece there. We obviously did a DCR. We just put in the Crawford tubes, which you can see here actually. And this is where we made, I think, a mistake. So we used the fibula skin paddle to realign the palate, the medial nasal wall, and then we also used the skin for part of the external skin where we missed some of it. And during the case also, despite the fact that we aligned the eyes because we want to really make sure his eyes were at the same level because he had really bad diplopia, we aligned them really well. We're very happy, but then because of the swelling, the eye was bulging, was pretty hard. And I thought, okay, we're going to have a problem. So we did a kentotomy and released the plate a little bit. So that way, we wouldn't run into risk. And I thought, worst comes to worst, we can always come back and place it back higher up if we need to. And everything went well. And, we were happy with this. And then, 3 days later, that's the skin paddle. Because, it had one perforator and doing all these, convolution, the palate, and then lifting it up. And we talked about it in the OR. We said, yeah, is it really? But it was very loose. It was there was no kinking. We thought about this and it was great. No. So we lost the skin paddle, but thankfully we harvested muscle with it. So actually the muscle mucosa out nicely. His palate is well reconstructed. There's no oroantral fistula and everything is fine. We skin grafted the part on the external. And that's how he looked in December. So 5 months later, everything has closed nicely. The flap has taken. He looks okay. But what I wanted to do, and essentially his ectropion, you can still see his ectropion. We still need to fix that. I want to fix the ectropion. We need to really fix the eye as well. And so after that is done, then, as I said, this is work in progress. We're going to then tackle the nose. And, this has been a now 4-year project. He has stopped smoking, and this is, I think, really good. The skin looks great now on the right side. But essentially, I'm happy that I got the chance to present this because I really need ideas. I've talked to my mentors in Cleveland, and we've poked a lot of minds, and everybody looks at me as like, this is tough. But so I know we're probably run out of time, but what do you guys think? What should we do next? I think the eye is the next target, but any other ideas? He has now a nice framework. We still need to fix his nose and the eye.
Dr. Alan, I saw you unmute, so I'm going to pick on you.
Okay, so I think a very nice job, very complex case. I think when we look at what we have right now is you've supported that orbit. There's still that ectropion that you mentioned to correct that probably shouldn't be very difficult to do. You have reasonable projection of the zygoma and zygomatico maxillary buttress there, and I think really what's going to really play a role is that nasal reconstruction. I mean, when you look at the side view, that's really what's affecting significantly the appearance. I think we need to bring that nose up. You're going to need a cantilever of sorts. So, you can think of various things to do. I think you're going to be trying to shy away from more free flaps. You probably exhausted all your vessels on the right side, and starting to play around with the left side would probably be.
Yeah, actually, I discussed not doing the scapula because we don't want to use vein graft. We ended up using vein grafts, even with the fibula.
Yeah.
It wouldn't reach with all of that.
Yeah. I love the scapular flap. Actually, the scapula, if you use that initially, you can use the scapular tip, and then you can get a really, you're working on the angular branch there, and you can get a really long pedicle if you're just taking the angular. And I've done those before, and I've had really very satisfactory results. If you're worried about that, if you need also the lateral border and a lot of soft tissue, that's a different story. But if you're looking at a scapular flap with the long pedicle, you can do a combination with the lat, and then you get a latissimus. You get the angle of the scapula for bone, and then you get a much longer pedicle, and that might allow you to avoid vein grafts. Not always, but we all try to shy away from vein grafts when we can. But I think it's a great flap, and initially might have been an option here. As for the nose, you need to cantilever that. So split clavarial probably bone might really help to bring that nose forward, and maybe use inner lining there to try to cover that inward. I don't know what's left from his of his mucosa in there, but that's another option to use to get that nose projected.
He doesn't have mucosa anymore, no septum, no nothing. I mean, it mucosalized on the underside of the paramedian. The other thing is, what I was going to say about him.
So Sammy, one thing I've used before, and works really nice as another lining, is using a pericranial flap. So if you open up the paramedian, you could use a very large pericranial flap underneath the skin, and then you bring it over, and you can really sandwich in and resurface the inner lining with that. It's a hardy vascular piece of tissue, and you can get a lot of it. So if you're thinking of another creative a way of resurfacing, getting coverage for any cantilever of bone that you want to place in, you can use that as well. Again, trying to avoid any need for any further free flaps.
100%.
Sorry, go ahead, and then we'll wrap up.
Can you hear me? idea for local flaps. I can show you a picture of exactly this. I just took it off my presentation for pericranial flap. How I can share my, I don't know how I can share my screen. For a second.
Yeah, and if you want, I'll stop sharing my screen. Also, you know, something to consider. This patient as well had, do I have the end show? All right, so the fact that he also still had the adenoid cystic carcinoma that removed from the temple area. So I waited a year and a half, but an adenoid cystic is notorious to be slow growing. So what would be the time frame you think? You know, we still went ahead and did the major reconstructive surgery for him, but so MRIs, waiting a year and a half, anything else you would do in that setting?
I would never wait for an adenoid cystic to come back. You'll be waiting a long time. So many
Right.
cases, and it might come back in the lung. So you want to give the patient as you know, the best quality of life. So I never tailor my unless it's really aggressive, and I've seen those very rarely. But
So here, Sami, one of the patients we did a pericranial. Here, see the big pericranial for lining. Yeah.
Yeah, we see it well.
Oh yeah,
Yeah,
that was
second one.
That's
I don't know.
beautiful.
It's not. I don't know. I'll show you. I'll show you just without putting the, and then and then you can put a forehead flap from the other side, I guess. Right?
right.
Yeah.
I mean, all local. But my question is the left side. Do you still have vessels there?
Yes. We
I
have not
mean,
touched the left side. We're still, these are the things we're thinking, like we try not to
forearm.
touch the left.
Yeah, forearm will work nice as well. The forearm is
Yeah.
very durable. I mean, we all have very good success with forearms.
And it has a long pedicle to reach to the other side.
And
So
it's a very long
that's
pedicle.
something we can
Yes.
do. Mhm. You know,
Forearm is-
interestingly, I'm sure, you know, I've never Dopplered a supratrochlear artery for a paramedian forehead flap. I don't know why I did that for him, but I didn't find any signal on the left side,
Oh,
only on the right side. And that's, you know, that was interesting because initially I planned to do the left side because the angle would be better. But then I'm like, interesting, no signal, then bounding signal on the left side. So I chose the left side, the right side, I'm sorry. The left side did not have any signal. So I don't know if I would venture and do anything with that forehead on the left side.
I never Doppler. Just you're lucky to Doppler this. Super.
I had a resident and I had a resident in with me and I was teaching him like, this is the artery, you follow it. And I'm like, there's nothing there.
Well,
And so, yeah.
thank you all for sharing these really complicated cases, some great ideas. Sounds like some are still, you've been going at them and really dedicated to improve your patient's quality of life for sure. But I really appreciate all your time and I think it's been a great discussion.
Great.
Thank you
very
very
much. Thank you
Great.
very much. And nice to meet you all, guys.
Yes.
Yeah, nice to meet you all.